All right, welcome back for part two. In this section, we're going to be talking about Pneumocystis carinii pneumonia. So like I said before, this is actually known by the new name Pneumocystis jirovecii. This is an atypical fungus, but it does have protozoal properties, and you haven't learned too much about protozoa, but do know that they have their own life cycle and various, I guess, considerations when it comes to how they're actually infective and what their natural history is. These fungi don't grow in a fungal culture, and what's interesting is that they do respond to antiprotozoal drugs. And the difference between most fungi and this unique one is that fungi will contain ergosterol in their cell walls, whereas pneumocystis will contain cholesterol. Also, the cell walls do contain beta-glucans, so we do see beta-glucan in most fungus, and this might actually play a role in initiating the immune response that causes the symptoms that we see with pneumocystis. This was once called Pneumocystis carinii, which is why the infection is still known as PCP. What they found, though, as they started to do more research, was that the P. carinii was what infected rats and guinea pigs and not humans, and the related organism that caused the infections in humans was the Pneumocystis jirovecii. This is transmitted via the airborne route, and most people are infected by the time they're about 4 years old. This can actually remain latent in a person until they become immune suppressed, and then the symptoms will start to show. While some can clear the infection, so they can be reinfected, the majority of them have been infected in the past. And transmission is person to person, and it can also be environmental. So the one interesting thing about this fungus is that for the most part, it only exists within the alveoli of the lungs. So this was one of the major killers in AIDS patients prior to the advent of antiretroviral therapy. And while these medications do reduce the risk, this is still one of the most common opportunistic infections that we see in people who are either not taking their medicines or have not been diagnosed formally with their condition. When we see this in the chest x-ray, this is going to be one of the major concerns inside the lungs, like I said. So one of the ways to diagnose is to get a chest x-ray. And unfortunately, this is going to be normal in about 25% of patients. If that's the case and you really do have a high index of suspicion, you want to make sure that you're getting a resolution CT, high resolution CT, while you're looking at the other potential causes. How this works is that, and we'll see a picture of this on the next slide, the chest x-ray is going to have diffuse bilateral interstitial alveolar infiltrates. That won't matter to you, and quite honestly, it's very difficult to tell what that means if you're not prone to reading or, I guess, keen on reading those x-rays. But when you see the term ground glass infiltrates, it's a good bet that there's something going on that is related to PCP. So we'll show you a picture of it, but just know that in exam questions and in cases, if I throw the term ground glass infiltrates in there for the chest x-ray results, there's something going on that is related to PCP. And other radiographic presentations could be possible. Rarely you will see extrapulmonary disease, and this is usually in people who are advanced immunosuppressed and people who are on some of the second-line prophylaxis treatments that we have as available. And in terms of clinical manifestations, this is pretty insidious, meaning that it's going to start low and symptoms will start to get worse over the upcoming days or weeks. Usually you're going to see fever and cough. There's going to be some difficulty breathing, and the breathing is much more rapid than it would otherwise be to try and catch up for the fact that breathing is so hard. Usually within 3 weeks before the presentation, there's going to be a non-productive cough. That cough will continue throughout the course of therapy. Fatigue is even with daily activities. So people who used to be able to take stairs with no problem, even people talking on the phone or shaving, might notice that they're feeling pretty worn down after they deal with this condition. And you will often see chills, chest pain, and unexplained weight loss. One of the major concerns is that obviously this does cause hypoxia, and this will cause crackles and rhonchi in the lung assessment in some cases. But it's also important to note that about 10% of them will be asymptomatic. So this is a picture of the ground glass infiltrates. Again, you're not going to be able to see pictures on the exams, but do know that if I say ground glass infiltrates, that's a good bet that the person is dealing with PCP. The picture on the top is just a picture of the wasting, and a number of things can cause AIDS wasting, especially in parts of the world that are still developing. And one of them is PCP, but there are others. So it's important to consider the entire history before you immediately jump to a diagnosis of PCP. This is strongly suspected based on clinical signs or symptoms, though a definitive diagnosis does require seeing the cyst inside the respiratory secretions. Most people will empirically treat while they're waiting for the definitive diagnosis because this is one of those conditions that could be life-threatening. And a definitive diagnosis is very problematic in that it's hard to get, but also that it could take several days. So you do not want to wait until you get the definitive diagnosis before you start to treat somebody for this condition. To get the sample, a couple of different options are available. The least invasive is to do an induced sputum. To do that, you would use hypertonic saline, which would be breathed in through a nebulizer into the lungs, which allows for ease of getting the sputum from the alveoli to the actual sample site. One of the things to keep in mind is that if you were just to do a sputum, like a cough sample, that tends to be very non-specific because you can actually see PCP in a lot of people who do not have the condition, because it does live in a person for the rest of their lives. The next option is to do a bronchoalveolar lavage, which is when induced sputum doesn't work, and if they're too dyspneic to actually produce any sputum. And the most invasive, obviously, is going to be doing a needle aspirate or the tissue biopsy. To treat, we want to consider a number of things. We need to consider the drug allergies because Bactrim, trimethoprim, sulfamethoxazole is the primary treatment and the primary prevention. So if we're dealing with somebody who has a sulfa allergy, obviously we can't use this drug. There are second lines that are available, and in most cases, these second lines are used before you try the extensive desensitization protocols. We have to consider respiratory status as well, and the reason that's the case is that for specific disease factors, we might be treating it a little bit differently, and I give you the examples here. Anybody who has an O2 saturation of less than 92 on room air should be given steroids or should be considered to be using steroids. And then when it comes to blood gases, which I have asked people to remember, so if a person comes in and they've got a blood gas that is such and such, you need to know how to treat it. And the examples here are mild, moderate, and severe. Based on the different lab values, mild disease is used with oral antimicrobials and no corticosteroids. Moderate is used with oral antimicrobials and corticosteroids, and severe is usually IV antimicrobials until they're stable enough to take oral drugs and corticosteroids as well. So know those numbers. They will come in handy during exams and cases. We have to consider some factors that might potentially inhibit oral absorption, including candidiasis, which is a common co-infection in these patients with PCP, or diarrhea. And then we have to consider the indications for hospitalization. So one of the things that's important to note is that PCP is always going to worsen over the first 2 to 3 days. And the reason for that is as you start to kill off the organisms, their dead pieces, those dead proteins and cells of the organism can actually lead to a pretty robust immune response because your body's trying to clear those. And if that's happening right inside the alveoli, that's going to make it very difficult to breathe, and people could deal with respiratory distress and potentially even death. And other things that might require hospitalization include the use of corticosteroids, any concern of compliance, if you really are concerned that a person isn't going to be taking their drugs. And as we will talk later, the use of IV pentamidine will always mean that a person has to be in the hospital. So preferred drugs in this case are going to be the use of trimethoprim, sulfamethoxazole. It's 15 to 20 milligrams per kilograms per day of the trimethoprim component. And when you're dosing Bactrim, the dosing is always going to be based on the trimethoprim component. This can be given orally or IV in 3 to 4 doses for 21 days. It does have excellent oral absorption, so if you can get a patient to swallow the pills and they're able to, using oral is always a good thing. And the dosing that is important for people who are adults and using oral is usually 2 double-strength tablets of Bactrim every 6 to 8 hours. You would use IV if there's a severe disease or if people can't tolerate the taking of the oral drug. This drug is used even if a patient had used Bactrim as prophylaxis, and this is actually still preferred in pregnancy, even though in the first trimester exposure there might be the potential for neural tube defects. And if you use it in the period near delivery, I'm pretty sure most of you have already heard about the fact that this can cause kernicterus. Some alternatives are used if there is an allergy to sulfa or if the patient can't tolerate the drug events due to the Bactrim, and those adverse events include rash, very rarely Stevens-Johnson or toxic epidermal necrolysis, fever, neutropenia, hyperkalemia, elevations in their liver function, and increased serum creatinine. Sulfonamide drugs should be discontinued if any of these are seen. Usually if there's a persistent rash or fever for more than 5 days after you've started the drug, their ANC goes down to less than 500. They're also dealing with hypotension and intractable hyperkalemia, or if fever and flu-like symptoms are followed by mucous membrane involvement, painful skin, target lesions, blistering, and desquamation. And you've all probably seen a picture that looks like this before when you talked about Stevens-Johnson syndrome in the dermatology classes. So when do you use adjunct corticosteroids? When you use those is based on the blood gases that we talked about before, but the doses that are usually used are prednisone 40 milligrams orally twice a day for 5 days, followed by 40 milligrams orally once a day for 5 days, followed by 20 milligrams orally once a day for 11 days. So that's the full 21-day course that they are on their antibiotics. And equivalently, if you can't get a patient to take those oral medications and you're using IV Bactrim, you can use IV methylprednisolone, and the dosing is 75% of the prednisone dose, again for 21 days. Alternatives to treatment include trimethoprim plus dapsone. Again, the trimethoprim is going to be based on weight, and it's 5 milligrams per kilograms TID. And in this case, dapsone is going to be 100 milligrams orally daily. You could also use atovaquone suspension, and for treatment, the dose is 750 milligrams PO/BID. This drug has a very low bioavailability, so it does need to be given with food. Primaquine and clindamycin is another option, and the primaquine dose is 30 milligrams of the base orally once a day, with clindamycin either 900 milligrams Q8H IV or 600 milligrams to 450 milligrams PO/TID. The reason that 900 milligrams is not given orally is that it's known to cause a lot of GI upset, and we would prefer to avoid that if we can. And then IV pentamidine dosing is 4 milligrams per kilograms IV once daily. For the most part, if I want you to know doses, I will let you know. The Bactrim dosing is very important. The steroid dosing is important. And I would actually consider the atovaquone dosing as well, because there is going to be something interesting that we see over the next couple of slides. So some of the things that are important to know about these alternative drugs: dapsone has a number of adverse events, and these include fever, lymphadenopathy. This has a sulfone hypersensitivity, so it's not a sulfa. It's not usually going to be an issue in people who have the sulfa allergies that relate to Bactrim. This one can cause GI upset, and some of the bigger side effects are methemoglobinemia and hemolytic anemia. So to prevent some of those from happening, we are going to check a lab test known as the G6PD test before we use those. And if a person does come up as G6PD deficient, we're not going to be able to use dapsone. This can still be used, like I said, in most cases of people who have a sulfa allergy because it's a sulfone drug. But if there is a serious reaction to Bactrim, serious reactions including Stevens-Johnson, serum sickness, or drug fever, then we are going to avoid dapsone. But in most cases, if it's a relatively rare reaction, something like a rash, I'm going to expect that dapsone is still an option for these patients. Trimethoprim in and of itself can cause GI upset and hyperkalemia. Primaquine is another drug that would require checking the G6PD before using. And again, if it's deficient, you don't want to use this drug. You do want to consider a couple of things well. And I didn't realize this until I got into practice and started working. When they were talking about the dosing was that 30 milligrams of the base. When you're looking at the actual way that the drug is prescribed, it winds up being prescribed as the phosphate. So if you're looking on the shelves for the 30 milligram or the 15 milligram, you're not going to find that. You'll end up finding something else. And so the equivalent dose for the 15 milligram base is 26.3% of the primaquine phosphate. And 2 of those is going to be what you use in these patients when you're using that drug to treat PCP. And this does only come as an oral tablet. So if you are somebody who is working with a patient that can't do oral, you have to consider the role in severe disease. And clindamycin, like we talked about, can cause GI infection, but it also leads to some issues with GI upset if you're using higher doses of the drug orally. So the IV doses are usually going to be higher than the oral ones. So what is this G6PD that I was talking about on the last slide? The formal name is glucose 6-phosphate dehydrogenase. The reason that the PD are actually highlighted in red is that if we were talking about the drugs we talked about on the last slide, the drugs that we want to consider are the primaquine and dapsone. So as a way to remember to check G6PD, think about primaquine and dapsone. And we probably aren't going to be talking about antimalarials this year, but there are some antimalarials that do cause the same problem. For this class, just know the primaquine and dapsone. And if it's deficient, if that enzyme is deficient in a person's blood, these drugs can actually cause hemolytic anemia. And what's interesting is that there are other chemicals and foods that can have the same effect in somebody who is G6PD deficient. And those include fava beans, blueberries, tonic water, which contains quinine, which is one of those drugs that we use to treat malaria, and artificial blue food colorings. So what are the symptoms of hemolytic anemia, or in somebody who has a deficiency in G6PD who's put on any of these or are eating any of these drugs? These can cause jaundice, very dark colored urine, tachycardia, and hepato and splenomegaly. When it comes to the alternative drugs, some of the other ones to consider are atovaquone, which can cause rash, though much rarer than some of the other regimens we're talking about. And this one does cause GI upset. So one of the reasons it's good to take it with food is not only bioavailability, but to decrease the GI upset. And a dosing consideration is that this comes as a very thick yellow suspension. And even the suspension, as thick as it is, has very low bioavailability. So this has to be taken with a fatty meal. But one of the things to consider is that this is not a pretty drug to take, and it doesn't taste as good as it potentially could. So sometimes treatment adherence to this is pretty difficult. And it is less efficacious than some of the other agents. So it's usually not used for severe or moderate illnesses, but maybe an option for mild conditions. And IV pentamidine, something that's really important to think about with this one is that the side effects are dose limiting. You're dealing with, in this case, nephrotoxicity, infusion-related reactions, either hypo or hyperkalemia, and glycemia. We're talking about pancreatitis, cardiac arrhythmias, hypotension, and hypocalcemia. So obviously these are going to be pretty life-threatening, and this is the reason that this drug can only be given in a hospital setting. And ideally, if it's given in a hospital setting, it should be given on an ICU floor or a floor where there's telemetry units available. This is much more side effects than the other regimens and is only used for severe illness. And this can also cause embryonic toxicity and death in the fetus, so this shouldn't be used in pregnant women. So how do you prevent this? We're dealing with a couple of things. First, primary prophylaxis, which is when the person has never had signs or symptoms of this condition. And when that happens, we're going to be prophylaxing when the CD4 count falls below 200. And we're going to discontinue that when the CD4 count rises above 200 for more than 3 months. So I have asked people about these cutoffs before, so it is important to know these numbers. Secondary prophylaxis, when a person has completed the 21 days of treatment and now needs to be put on something to make sure it doesn't happen again. We are going to continue the oral medications in the way we're going to be talking about on the next slide, and we're going to be discontinuing when the CD4 count falls, rises above 200 milligrams for 3 months. And is there a way to prevent exposure? Unfortunately, there really isn't, because the organism is ubiquitous and most of us have already been exposed to it before we're 4 years of age. But one way to keep other people from getting it is to keep hospitalized patients who have PCP away from other people who are immune compromised, just to avoid the possible person-to-person exposure. Preferred regimens for prevention, again, are Bactrim, but this time it's 1 double-strength tablet a day. A single-strength tablet can work, which might potentially reduce adverse effects. One thing that they also found was that you could do a double-strength tablet 3 times a week, which is good at reducing adverse events. But if you've ever worked with patients who are trying to remember to take the pills, and did they take it yesterday or did they not, and do they have to take it today, sometimes it gets very hard to remember, which might actually be a problem with adherence. Some alternatives are Dapsone 100 milligrams a day. Again, you have to check a person's G6PD before you use that. Atovaquone, the difference between treatment and prevention is that where you're using this for treatment, it's 750 BID, but when you're using it for prevention, it's 1,500 milligrams a day. And this time, instead of using IV pentamidine, you're using aerosolized pentamidine, which is 300 milligrams once every 28 days. Some notes about the aerosolized pentamidine that are important for you to know. You have to use this with a very specific nebulizer. They can't use their nebulizers at home to give this medication. It doesn't have the same side effects as the IV pentamidine, but what it does do is cause a lot of cough, wheezing. And to prevent that cough and wheezing, you're going to be pre-treating with albuterol to prevent some of that. You also should be screening these patients for active tuberculosis, which we will talk about in a couple of weeks, with a chest x-ray before treating with pentamidine. And the reason for this is that if you have somebody who has active TB and you're inducing coughing in those people, it could actually put the healthcare workers that are working with them at risk for possible TB exposure.